bleaching of the discolored teeth. Bleaching means lightening of the tooth, because yes, using some chemical oxidizing agent, so the organic pigment of the tooth, when it is removed or it's bleached, or it gets whiter. The tooth color is determined by the dentine and the enamel and the different thickness, and that depend on the thickness of enamel mostly in the permanent teeth, because the dentine thickness is fixed. So the scattering of the wavelength of the light in a blue range will give me the color of the tooth. Shade selection in prosthetic, it is a very mandatory stage before sending the design and the impression to the lab. It's a well-known fact that the first impression or the first look to the patient teeth is mostly the best matching. And it's advisable not to take long time, more than 5 seconds, to select the color of the tooth. Otherwise, the eye fatigue will be there, okay, and it will affect our vision and decision. It's always recommended in the patient in the dental clinic to have some blue color, like a blue color scene or a picture, or even painting wall or anything to be in blue, to the dentist to relax the muscle from time to time. And especially it is used, and it's advisable to be used when you have 2 shade matching trials. We have many causes of discoloration, but we can put them in 2 categories: either extrinsic discoloration or intrinsic discoloration. The extrinsic, from the name, you know what does extrinsic mean. Intrinsic, it is a stain that happen and occur within the development of the tooth, and it enters the hard tissue. For the extrinsic discoloration, it's usually produced on the surface of the tooth, okay, and it's due to the attraction of different type of material to the tooth surface, and that play a critical role, okay, in changing a color. There are many causes for such a discoloration or such an attraction to the color on the tooth surface. Either it will take a long period of time so that the tooth will be discolored, and these forces, like the electrostatic forces or the van der Waals forces, while for a short period of time we have the hydrophobic effect and the dipole force and the hydrogen bond acting to discolor the tooth. Such an interaction will allow the chromogenic agent to be precipitated on the surface of the tooth and causing pigmentation. Extrinsic discoloration, mostly it is there on the enamel, okay, or the acquired pellicle. Either they are metallic or non-metallic in origin, and we can remove them by any oral prophylaxis, which means that using the rubber cup and pomace is fair enough to remove them. Such a type of pigments, the extrinsic one, they have a certain classification. Either they are a direct dental stain from a chromogenic bind to the tooth structure, a stain like from a coffee or coffee, wine, metal, some bacterial product, tea can do. So they are directly staining. Okay, there is another type, we call them N2, These are direct dental stain with colored material that change the tooth color after joining the surface, not only precipitating on the surface. Okay, the first one, it was just a precipitating of this material, and two is changing, joining the surface. The pigmented material, mostly they are bonded to the surface of the tooth, then they will change the color, like the yellow pigmented plug, the coffee, interproximal, or the cervical area, which mostly is much more darker than the other part of the tooth. N3, this is the first two, they were direct. The third type, which is N3, it's indirect dental stain. So colorless material, pre-chromogenes that bind to the tooth. Carrying these material will carry chemical reaction that cause a dye to convert to the chromogenes and pre-chromogenes, like the fluoride and the chlorhexidine. Most of the patients who are using chlorhexidine and that type of, and most yes, the chlorhexidine can give you, it's very good, that's right, it prevents the accumulation of the plug. Mostly it's used for handicapped patient, for example, people who have some sensitivity into tooth, some people who have a problem with the gum. A mouth gargle or toothpaste with the chlorhexidine is good, but its disadvantage that it will cause yellow pink discoloration of the teeth. So this is an indirect dental stain. This is a colorless material, but it will cause chromogenes change. Chromogenes, which mean color change. Okay, it will cause a chemical reaction and will dye the tooth. The extrinsic discoloration, as we mentioned before, they are within they will be incorporated with the development of the tooth structure, the intrinsic one, while the extrinsic one, they are at the surface and can be removed with pumice, like cigarette, cigar, pipe. They will cause yellow discoloration, and mostly the cervical area will be affected. Chewing tobacco also, due to chewing and the pressure from the occlusion, the stain will go inside the deep portion. It's a deep stain. Coffee, tea, they will cause some tenacious discoloration, usually brown and to black discoloration. Plug, chromogenic bacteria, mouthwash, as I mentioned. Some food like the curry, cooking oil, fried food, foods with coloring, berries, beetroots, all of these. Medication like antibiotic, erythromycin, amoxicillin, clavulanic acid, they will cause some yellowish discoloration too. Iron supplements, especially in children, pediatric patients, they will cause a black discoloration. These are discoloration of the iron. While the intrinsic discoloration, here, the discoloration comes because of some structural form within the composition of the dental hard tissue had happened. So these are the stains, either in enamel or in dentine, because such a material, it was incorporated within the structure, like a tetracycline stain, the dentogenesis imperfecta, fluorosis, byproduct released in the dentinal tubules, other byproducts that are released in the dentinal tubules due to some illness, for example, bilirubin because of jaundice. Okay, trauma. The trauma which will cause breakdown of hemoglobin in the pulp. Some pigmentation will be escaped from a certain medication or from restorative material like amalgam. Okay, so if we start to take examples for them, we have the tetracycline discoloration. So the tetracycline discoloration is an intrinsic discoloration, and it's expected to be there from the second trimester in the utero to roughly 8 years after birth. So tetracycline molecules appear to chelate the calcium, and it enters the chemical structure of hydroxyapatite. And mostly the tetracycline stain, it involves the dentine. Definitely the severity of the stain depends on the dose and the duration of the dose. Okay, type of the tetracycline. So we have first degree. The first degree, the discoloration is light brown to gray stain, and it is uniformly distributed throughout the crown. This type, it responds well to the bleaching, but it needs at least 2 or 3 sessions. A second degree, it looks darker gray staining. They are more extensive than the first degree. They are not distributed in bands. They respond well to bleaching, but within 4 to 6 sessions. Third degree, these are dark gray to blue with marked bands. You can see here in the picture, the stain is distributed in bands. Mostly it responds to bleaching, but it is too difficult to bleach the bands. Okay. Sometime after bleaching, we use veneers. The fourth degree include stains that are too dark to attempt vital bleaching. Even definitely we have 2 techniques for bleaching, for a vital tooth and for a non-vital tooth. So this type does not respond to bleaching. Second type is the fluorosis staining, the molten enamel. It happens when the children, they ingest excessive fluoride. Mostly it's within the water. So during the development of enamel and dentine, damage occur within the enamel forming cells. Usually they start from the third month of gestation through 8 years of life. So if the concentration of a fluoride was more than 1 part per million, the normal is 1 part per million, the concentration, but if it increases to 4 part per million, so such a moderate to severe discoloration happens. And definitely it affects the ameloplasts cells themselves. So the metabolic alteration of the ameloblast will give you a defective matrix and improper calcification. Does it have types? Yes, it has a simple type. While the tooth appear brown, pigmented, smooth, and still the surface is smooth, this responds well to bleaching. The opaque fluorosis, the tooth looks flat, gray, white fleeks on enamel surface, poorly respond to bleaching. Sometimes it's too severe, so you can see fluoride staining with pitting, defect in the enamel formation. So this need a treatment by a composite resin bonding. A third type of discoloration happens when there is a pulp necrosis, either related to a trauma. So in such a case, trauma can cause hemorrhage. Hemorrhage means that the blood vessels are inside the pulp are ruptured and the blood hydrocephalus Locally, it will be driven to the dentinal tubules, RBC. They will be inside the dentinal tubules. With the time, they will undergo hemolysis, and it will liberate hemoglobin degradates, and this hemoglobin will release iron, and this iron will form the black compound when it reacts with hydrogen sulfide, and it will be iron sulfide, and that is normally happens in the oral cavity. So immediately after trauma, the patient will come to you. It's normal. The tooth looks pink to orange, but you give it a time, because if the vitality of the tooth was recovered, so which means that the vascularization returned to normal, everything gets fine. But if the discoloration gets worse, gray to black, then we have to treat the. Sometimes we have a pulp degeneration happens without hemorrhage, but again it will cause discoloration. The discoloration comes from the necrotic tissue that contains various type of protein. That protein will degrade, and the degraded product are grayish in color, and they will change the color, and the tooth again respond well to a non-vital bleaching technique. Causes it will, they will can cause discoloration. A silver nitrates, which was used, and maybe still some old school dentists are using such a material for to kill the pulp tissue for pulpotomy, they will cause also bluish black discoloration. Volatile oils, they will cause yellow brown stain. Iodine create a brown, yellow, or orange stain, and we use iodine to sterilize a wound, or to we use it in pre-surgery. Root canal sealers that contain silver, they will cause black stain. MTA, because it contains silver, it will also cause discoloration. Pin also will cause blue-gray discoloration when it reflects its color on the labial surface, as in this picture with the lateral. So the discoloration also sometimes can be there because of some systemic condition, like RH incompatibility between the mother and the child, some breakdown of excessive number of erythrocyte discoloration in the blood cells, and can cause a stain of the dentine. Jaundice also can cause a stain of the dentine to a bluish green or brown. Porphyria, it's a very rare condition, but again the tooth will look purple in color, as you can see here. Some genetic condition like amelogenesis imperfecta, they will interfere with the normal development of the enamel matrix. They will cause discoloration. Some acquired illness like cases of cerebral palsy, serious renal damage, severe allergy, neurologic and other traumatic injury, they will cause some developmental change in enamel. Enamel hypoplasia due to deficiency of vitamin A, C, D, and calcium and phosphorus. Any deficiency of these can cause enamel hypoplasia. And the tooth, the deformity will be within white spot, will respond poorly to bleaching. Some discoloration can be caused by hereditary factors. Some of them, it's a family genetics, they have lighter teeth, some of them have a darker one. dental caries, especially in the interior. They will, their shadow will appear and as a discoloration. The treatment should be the removal of the caries and filling the tooth. Some deeper pigmentation can be there because of bacterial degradation of food debris area of tooth decay or tooth decomposition. So bleaching in such cases is not necessary because it will be ineffective. Discoloration due to aging. Definitely with aging we will have increase in the thickness of dentine. We have some exposed dentine cervically due to erosion, some exposed dentine occlusally due to attrition, increase in thickness of the dentine, the yellow color of the dentine in comparison with the with the enamel. The tooth will look yellower, so the increase in the thickness of the dentine due to the formation of the secondary and tertiary dentine with the time. So advantage. So there will be no advantage of a bleaching here. The teeth will be insensitive. If a trauma causes a pulp necrosis, discoloration became sometime a patient come to you post-trauma. Once check the tooth, sometimes the tooth will be discolored with pink color. Okay, just give it a time after trauma if the tooth was vital, so give it a time from 2 to 3 months. If the vitality gets normal and revascularized again, this pinkish color will be. So in the bleaching we have vital and non-vital teeth. For a non-vital teeth we have office bleaching technique, we have walking bleaching technique, and we have junction where I should use my non-vital bleaching. So what shall I do? I should clean the opening. I might use acetone or alcohol to clean the canal from any remnants of proteins, and so you can see it's all clean. And then I bleach using hydrogen peroxide. The complete seal is very important. And then I bleach, and the bleach could be solution, could be gel, so not to escape to the root canal or in between the root canal filling, especially when they are porous, because the material I'm using is acidic and it will cause discomfort and might end up to a loss of the tooth. So the picture can show you how I clean, how I seal the root canal filling, then the remnants of the tooth should be bleached. And as I said, acetone, chloroform are used to clean the cavity at the end. How many type of, I have many bleaching agent nowadays. Mostly the bases, the most important base is hydrogen peroxide, or a material when it will break it will form also hydrogen peroxide, like the carbamide peroxide and the sodium perborate. So what a hydrogen peroxide can do, this is not a stable material in an aqueous media, so it will remember when you use hydrogen peroxide, the material should be new. I mean, you should not you should not depend on an old material. When I say this material is active, which means that once it touches anything, it will react. Okay, when it is kept in a bottle for a long time, it will react. So always use a fresh material. This hydrogen peroxide will break, forming oxygen, and this reaction can be accelerated by heat, whatever the type of heat is there. Or we can, yes, heat, the addition of sodium hydroxide or light. all of these all of these are activating agent for this reaction. So this oxygen will be really active when there is an acidic media. I mean, when they will break down to H2O and oxygen. So this oxygen, they will able to promote formation of ion perhydroxy. The ion perhydroxyl, which is the HO2, it is the superperoxide. So it needs an alkaline, needs to become alkaline, and the optimum pH for this is about 9. So the bleaching efficiency depends on the concentration of H2O perhydroxyl free radical. Okay, depend on the concentration and depend on the time of application. The carbamide peroxide, it's organic material. They are crystal-like. They are urea with hydrogen peroxide. So they are used in different concentration. I forget to tell you that the first material, mostly the concentration of it is 30 to 35%. While when there is a carbamide peroxide, then the hydrogen is 3%. It will break down in a hydrophilic environment into peroxide. The sodium berborate, the third material, is also an oxidizing agent. It's present as a powder. It's stable when it's dry. So I have no problem when it's dry. I can store it anywhere. But with the presence of acid or warm water or just the water, it breaks to sodium metaporate and hydrogen peroxide with nascent oxygen. Before starting with this material in the patient mouth intraorally, we have to tell the patient that don't rely on bleaching too much, because bleaching results are not predictable and they can recover very easy. Again, either I will use the hydrogen peroxide directly on the tooth, or I can use a hydrogen that comes by a byproduct of chemical reaction when I'm using the carbamide peroxide and the sodium berborate. Hydrogen peroxide used in dentistry to bleach at a variable concentration from 5 to 35%. It's effective. Why this material is important? Because it has a very low molecular weight and can penetrate the dentinal tubules and the tooth structure to break down there, releasing oxygen and bleach the tooth. But before starting the bleaching, a dentist should clean the caries, should restore all the tooth, and before treatment a radiograph need to be taken to check all the root canal filling if the tooth was non-vital, and because the root canal filling should be sealed coronally for two purposes here: not to allow the organism leakage and not to allow the leakage of the bleaching agent to the apical area. Otherwise, we will lose the tooth. It's very helpful to take a photograph. It's not only an x-ray. It's a photograph needed to the patient to prove that we have done the bleaching pre and post treatment, because you might bleach the, the tooth of a patient with the first. Again, the patient will not stop drinking coffee and tea and so on, and next day he will come asking you for his money because you never did the bleaching. So you should have a photograph to prove vital. We should use the rubber dam. Rubber dam is very important to isolate the tooth, otherwise the acid will burn the soft tissue. And to protect the lips, you use the rubber dam. You weight the gauze with hydrogen peroxide. You apply the hydrogen peroxide, then you apply your heat through a light, through a laser, through halogen. We have the halogen, we have the xenon lamp, we have the laser. Definitely when you are using the normal light and the halogen, it might take 15 to 20 seconds, but if you are using the laser, if you are using the halogen and the xenon lamp as a heat source, you need 15 to 20 minutes. But if you use the laser, 30 seconds are long enough to bleach. It's the upper limit for the time used when to bleach the tooth when you are using the laser. We have many types. We have another type in the office, that we have another method in vital bleaching when the tooth is vital. You can fabricate a study model. You take an impression, you pour the cast to the patient, and then you use some liticure or some material to make with the use of heat and a vacuum. You can make a night guard to the patient, and that mouth guard with a thickness of 0.2 to 0.3 inch acid with the carbamide peroxide, and he might sleep. It's a gel-like material. He might sleep within or within 1 or 2 hours, or maybe more. The tooth should be bleached every day, not more than 3 to 4 sessions. Okay, and then after that, the patient can rinse his mouth. Okay, I mean, he should rinse his mouth. For the non-vital tooth, we have also in-office bleaching. And the in-office bleaching, I just mentioned it before, but this is a very old type of bleaching. There was no light for heating to accelerate the reaction to get the free oxygen. Again, we were before using the cotton to be applied inside the cavity, the cotton fiber, and then with the syringe we can immerse this cotton with hydrogen peroxide with the glass syringe, and then when it's wet completely with the hydrogen peroxide, then we can, and the excess of that material should be wiped, and then we can heat a tip of and leave it inside the patient mouth to bleach the remnant part of the tooth. This heat application can be repeated 3 to 4 times. Always remember, using fresh hydrogen peroxide is very important. Always between this visits of a bleaching, try to seal the pulp chamber. You can use this after heating for several times. You can just renew the hydrogen peroxide inside the cotton and put it in the patient mouth and seal the cavity with a temporary, and let the patient goes home. For 24 hours he can have the bleacher in his mouth, and then he should return back. If the shade is still darker, you bleach again, and so on till you get the color you need. The out office bleaching. This is again, we can clean the cavity in the same manner using the sodium perborate, and the sodium perborate will release hydrogen peroxide, giving me oxygen, and the sodium perborate, it's just a white powder which decompose into sodium metaporate and hydrogen peroxide. The most important thing is the hydrogen peroxide. Okay. A complication of the internal bleaching. Yes, there will be some complication, especially if the concentration of acid was high, or sometime because the thickness that is left in the tooth structure is very thin. So such an acid, they might escape through the dentinal tubule. They might cause inflammatory response, end up to dentine resorption. Some alternative theory that says that some bacteria will leak into the pulp chamber through the gingival cervix and via dentinal tubule, or directly from the excess cavity, and will cause resorption. Root resorption can be arrested, if it happens, by applying calcium dical, okay, which is the calcium hydroxide. It's better to use an oxidizing agent as a gel or a paste. You can control it more than being a liquid. Rubber dam is a must, because any drops, if it's bleached, it will cause burning. And if that burning of the lip, burning of the gum, so it's better to use a copious volume of water to treat that. Any failure of a bleaching, yes, it can happen when the discoloration is by a silver amalgam. It poorly responds to bleaching. Okay, some incomplete removal of composite resin or glass ionomer cement, also because this is a material that can prevent the bleaching agent to reach the dentinal tubule. Remember, hydrogen peroxide can, the one that was used for bleaching, if it was expired, it will not work. That's always use a fresh component of hydrogen peroxide. Over bleaching, it happens sometime. So it happened, and sometime after bleaching, the tooth may get darker. So it's very important not to bleach. Okay, try to monitor the color. Brittleness of the tooth, yes, because bleaching will weaken the tooth structure. So bleaching is there for a vital tooth and a non-vital tooth. For a vital tooth, we can use a powder bleaching and the thermocatalytic and the fourth. This is an in office. You put the bleacher and then you use the heat. Okay, and the process will be for a short time. While for the when you want the patient to go home and do the bleaching, then you will use the material like a gel, which is the carbamide. Then you will use the night guard. The bleaching for the non-vital tooth, mostly it is with one tooth. Either it is in office, where we will put the cotton and the material, and we will use the light, the laser light, the halogen light, and all of these source of light, we will use them as a heat, so the hydrogen peroxide will be reaction will be facilitated, and we can bleach the tooth, or we will put the cotton and the bleachant inside the cavity of the tooth palatally, exactly in the excess opening, and we seal the cavity and leave the patient to go for a time to check for the next recall the color of the tooth. So these are the techniques, and thank you.